So in moving forward, clearly, almost for the last decade, we've successfully, as Danny pointed out, extended progression-free survival, more than doubled, sometimes tripled overall survival. It's been an absolutely dramatic time for most kidney cancer patients. But having said that, where we have fallen short is that chronic therapy is required. Coming off therapy, disease progresses. Oral agents are still associated with significant, potentially life-changing side effects that change how people do. And we need to be looking for new approaches. And at this past ASCO and throughout our literature, it's very clear that we're revisiting, Jan, the role of immune-based therapy. For those of us that have given immune-based therapy for years, one recognizes that in our practices, if you ask the question, what's the most likely therapy a person received for a period of time and then had an unmaintained remission for years or decades, it's IL-2. And yes, IL-2 is difficult to give, and yes, IL-2 doesn't work in most people, but it does tell us something about biology. So the question, Jan, is are we revisiting the role of immune therapy in kidney cancer, and if so, how? And are we doing it the right way? Did we learn the right lessons from the first experience? Are we applying it in the second experience? And are the endpoints, the biomarkers that we're looking for in the patient populations, the right populations? That's a lot on your plate, but take a stab at it.
Thank you. Yes, immunotherapy is having a resurgence of interest, no question about it. Yesterday morning, we actually had a Society of Immunotherapy of Cancer symposium to talk about different approaches. And I will talk to your specific question, which is about the new understanding of taking the brake off the immune system with checkpoint inhibitors. But I wanted to just mention one point that was made, which is still underexplored and needs further evaluation, which is the combination of stereotactic radiation with immunotherapy to get an abscopal effect on tumor. And that has not been well explored in humans, but very well documented in animals. So that's another direction that immunotherapy is going.
So let's just be clear so the audience understands. So by an abscopal effect, you mean that giving local radiation therapy to a targeted tumor could alter the antigenic expression in a way that might allow for an immunologic reaction at sites that weren't irradiated.
Correct. Correct.
And you think that whether it's in kidney cancer, obviously melanoma or other diseases, that we need to be thinking about the benefits of antigen exposure in the context of further immunotherapeutic approaches?
I do.
Okay.
And then the checkpoint inhibitors, which of course are fascinating, which is that we have a system in the immune system where we stimulate and then we can control it with regulatory T cells or with other modulation of immune expression. And now we have discovered that both anti-CTLA-4 antibodies and now most recently anti-PD-1 and anti-PD-L1 antibodies can take the brake off the immune system and allow the immune system to identify and progress against antigens that are tumor specific. And you know, the clinical data are very compelling. We're seeing responses not only in kidney cancer and melanoma, but even in lung cancer and prostate cancer. So it's suggesting that tumors can be more immunogenic than previously believed with the advent of a different type of modulation of the immune system. So the clinical trials, are we doing them in a different way? We're looking at response and we're looking at duration. Whether we can combine these, we don't know. And whether we can combine them with each other or with other types of immune therapy, we don't know.